So, which are lymphomas that can cure in 2025? The answer is all lymphomas can be cured. So, a brief introduction before I proceed to a case-based discussion. So, each type of lymphoma, it results from a lymphocyte which is arrested at a certain stage and then transformed into a malignant cell. And there are more than 60 types of lymphoma. If you see the WHO classification, there are so many lymphomas, it's difficult to remember all of them. So just to simplify everything in our mind, in our heads, in our clinical practice, we narrow it down to Hodgkin and non-Hodgkin lymphomas. Non-Hodgkin lymphomas are B-cell lymphoma, T-cell lymphoma. Again, B-cell lymphoma, we further narrow it down to high-grade and low-grade lymphomas. And in the same way, T-cell lymphomas are more or less aggressive lymphomas, more aggressive than B-cell. And the types are PTCL NOS, primary T-cell lymphoma NOS, then anaplastic large cell lymphoma, adult T-cell leukemia lymphoma, and the list is really long. Coming to Hodgkin lymphomas are the classical Hodgkin and the non-classical, which is the NLPHL or the nodular lymphocyte predominant Hodgkin lymphoma. The classical lymphoma, we all know, mixed cellularity, nodular sclerosis, lymphocyte rich and lymphocyte depleted varieties. So coming to the case-based discussion, case number 1. So a 68-year-old man presented with generalized lymphadenopathy with progressive weight loss over last 4 months, approximately 8 kgs. On evaluation, CBC showed hemoglobin of 9 gram per DL, TLC was 4600, neutrophil 73, lymphocyte 12%, platelet count was 1.56 lakh, LFT KFT was within normal limit. Workup for the TB was done, it was all negative. FNAC was done from the cervical lymph node and that showed atypical lymphoid population. So what next? How do we proceed ahead? So whenever this kind of history, a patient comes with this kind of history and reports, so we proceed with excisional lymph node biopsy followed by immunohistochemistry for characterization of the atypical lymphoid population, followed by PET-CT whole body bone marrow aspiration and biopsy because there was anemia, and we always do LDH. So on excisional lymph node biopsy, it was a high-grade NHL. On immunohistochemistry, it was further characterized as DLBCL with Ki67 of 70%. PET-CT showed generalized lymphadenopathy, cervical, mediastinal, retroperitoneal, FDG, avid lymph nodes were there, with increased uptake in skeleton, with bone marrow was involved, and LDH was high. So how to plan treatment? Is it plainly R-CHOP, we go ahead with R-CHOP, or is there something else that we need to consider? So whenever this kind of report comes, so there are a few points we have to consider. First thing is the performance status of the patient, that is important. Second thing is we do a cardiac evaluation of the patient. Ejection fraction of the patient is important. Next is we prognosticate the patient with international prognostic index, and then there is CNS IPI, which is required for, we need to find out how much is the probability of CNS involvement in this case of lymphoma. And there are certain points in IPI and CNS IPI. IPI age less than 60 or more than 60, stage 3 or 4 is +1. Then ECOG performance status less than or equal to 2 is again 0, more than 2 is +1. Then if LDH is high, +1, more than one extranodal site, +1. In CNS IPI, apart from these points, kidney or adrenal involvement, +1. So this case was 68 years old male, DLBCL stage 4, IPI was 3, CNS IPI was 3. So is R-CHOP still the standard of care in DLBCL, or is there something else? So DLBCL is basically a very heterogeneous disease, and since the advent of R-CHOP in 2002, 50 to 70% of patients get cured with R-CHOP, but still 30 to 40% patients, they are non-responders, they do not respond. They are either primary, refractory, stable disease or progressive disease. So have we found an alternative, or can we do something for these patients? So as per the NCCN guidelines, stage 1 and 2 DLBCL patients, R-CHOP, and apart from R-CHOP, a new therapy has come, that is Pola R-CHOP. So Pola RCHP. So basically from R-CHOP we have removed vincristine and we have added a new drug that's called polatuzumab vedotin. It is a monoclonal antibody, or you can say it's an antibody drug conjugate, which has a cytotoxic agent in its belly and it targets CD79B, which is present on lymphomas. So Pola RCHP is the new drug which is there for DLBCLs, and for stage 1 and 2, stage 2 extensive or stage 3 or 4, Pola RCHP has to be taken into consideration apart from R-CHOP. At least it has to be offered to the patient. In cases of patients with poor left ventricular function, we basically do other things like in R-CHOP, we can use liposomal doxorubicin, or we can go for DAR-EPOCH, where there is a 96 hours infusional regimen. It is supposed to be less cardiotoxic, or we can replace doxorubicin with other agents such as etoposide, or we can add procarbazine or something else like gemcitabine into the regimen. For very frail patients and patients who are more than 80 years of age, there we can go ahead with mini R-CHOP, or we can again use these agents which were used for poor cardiac function patients. Those chemotherapy regimens can be used. So what is the BSH guideline for DLBCL? For stage 1 and 2 disease patients who do not have bulky disease and their IPI is 0, there we can go with 4 cycles of R-CHOP with additional 2 cycles of rituximab. For patients who are still older, 61 to 80 years of age, there we have to use PET scan. PET-based therapy has to be used. So after 2 cycles of R-CHOP, we have to do an interim PET, and if the patient has achieved complete metabolic response, which is DS scoring, if it is between 1 to 3, then we can give another 2 cycles of R-CHOP and stop. But if the patient has not achieved adequate response, in that case we have to give another 6 cycles of R-CHOP. And for other patients who are less than 80 years of age but the IPI is high, if it is more than or equal to 2, there Pola RCHP is the standard of care in these days. If we cannot offer Pola RCHP, we can still give R-CHOP, and in cases of extensive disease or stage 3 or 4 or stage 2 IPI more than 2, we can give 6 cycles of R-CHOP or Pola RCHP. So there were certain regimens which were compared for the non-responders or the refractory disease patients. So there's one famous chemotherapy regimen. It's called dose-adjusted EPOCH-R. So basically it's a 96-hour infusional regimen where we give doxorubicin and vincristine and all the same medications which are there in R-CHOP along with etoposide in an infusional basis. And we compared, and it is more toxic and more intense as compared to R-CHOP. So this study compared the efficacy and safety of these 2 regimens, and it was published in 2019. And as per the study, there wasn't much difference between the progression-free survival and the overall survival between these 2 regimens in case of DLBCL. Then there were certain particular subtypes of DLBCL where our DAR-EPOCH was found to be better as compared to R-CHOP, and those subtypes were high-grade B-cell lymphoma with MYC or BCL2 rearrangement. They are called double-hit or triple-hit lymphomas, or primary mediastinal B-cell lymphomas, or HIV-associated DLBCLs. Apart from that, if there is high-risk IPI is high, or if it is a GCB type, ABC type, regardless of whatever is the subtype, R-CHOP is still better than DAR-EPOCH because DAR-EPOCH has other toxicities also. Then there were other modifications which were done on R-CHOP to find out. So even if we are not able to give DAR-EPOCH, which is more intense, more toxic, can we do something with R-CHOP and make it better, to make it to make those patients more responding? But none of the studies were helpful. And those modifications were, suppose R-CHOP 6 cycles of R-CHOP were followed by rituximab maintenance, or R-CHOP 21-day cycle was changed to R-CHOP 14-day cycle, or 6 cycles of R-CHOP were converted to 8 cycles of R-CHOP. All these studies, it showed that there wasn't much difference in the overall survival and the progression-free survival. Only one study that showed that there was better response or better overall and survival and PFS. That study was where 6 cycles of R-CHOP were followed by len maintenance or lenalidomide maintenance. This study showed that len maintenance followed by 6 cycles of R-CHOP was considered to be better in cases of DLBCL, especially in the ABC subtype. Finally, the new drug and the new regimen which has become the standard of care in DLBCL. This study was published in 2021 in NEJM, polatuzumab vedotin in previously untreated diffuse large B-cell lymphoma. As I already told you, polatuzumab vedotin is an antibody drug conjugate, so it carries a cytotoxic agent which is vedotin or MMAE, and it has a binding target for CD79B. So it specifically targets DLBCL, the bad cells, or the lymphoma cells. And in this study, it was seen that pola-R-CHP was better in terms of progression-free survival, event-free survival, and disease-free survival. But at 2 years, the overall survival was more or less similar. There wasn't much of a difference. Then updated 5-year results were published recently, and it was seen that the 5-year TFS was better in case of pola-R-CHP. It was 64.2% as compared to 59%. Even the overall survival was better at 5 years, and the 5-year disease-free survival was also better in case of pola-R-CHP. So coming back to the case 1, this patient was 68 years old, DLBCL stage 4, IPI3, CNS IPI3. He was given 6 cycles of pola-R-CHP. He tolerated it really well, and at the end of the therapy, he achieved complete metabolic response, and even the interim PET was good. He is at present doing well and 3 years post chemotherapy. Coming to case 2, a 36-year-old man presented with generalized weakness with cervical swelling noticed for a duration of 2 months prior to his OPD visit in hematology, and this was followed by hoarseness of voice, and his CBC was more or less okay. Hemoglobin was 11.8, TLC 12,800, platelet 1.35 lakh. PET-CT showed metabolically active generalized lymphadenopathy along with splenic and skeletal lesions. Cervical lymph node biopsy gave the diagnosis of DLBCL ABC type, and Ki67 was 55 to 60%, bone marrow was not involved, IPI was 3 in this case, ejection fraction was all good. This patient was, again, because he was young, his overall performance status and everything was good, we gave him pola-R-CHP. But the problem was, despite giving pola-R-CHP, his serial PET-CT scans done during and at the end of the treatment were suggestive of stable disease. He never achieved even DS score of 3. It was always 4 or 5. So what do we do in this case? So this was a case of primary refractory DLBCL. So what do the current guidelines say? So as per the current guidelines, if the patient is transplant eligible, and by transplant eligible what I mean is a person who is younger than 60 years of age, doesn't have much of comorbidities, has good cardiac status, PS performance status is good. In such patients, why is it going like this? In such patients, if the time to the next therapy, if it is less than 1 year, then the standard of care in the current times is a CAR T-cell therapy. But if the time to requirement of the second line therapy, if it is more than 1 year, then the standard of care is still the salvage high dose chemotherapy followed by autologous stem cell transplant. If the patients relapse after these 2 regimens, if a person is not responding to CAR T or has relapsed after CAR T, we can go for transplant, or we can go for other third line agents such as epcoritamab, glofitamab, and further down the list is other list of sophisticated antibodies or the chemotherapy regimens. Actually, they are not even available in the market. They are available in US or on trial basis only. But what is available in India right now is CAR-T and autologous stem cell transplant and POLA-based regimens. If the patient is transplant ineligible, then what to do? Suppose someone who is 65 years old and he has relapsed, what to do? If the time to next treatment or the second line treatment is still, if it is less than 1 year, so we can think or we can consider that it is more or less chemo-refractory disease, and in such patients, we should go for a CAR-T. If it is more than 1 year, then because he is transplant ineligible, we'll have to go for other chemotherapies, and we can adopt a POLA-based regimen such as POLA-BR. And again, further down the list, it's the same chemotherapy regimens that we can use. So there was a trial which was done on CAR-T in high-risk large B-cell lymphoma, and it was seen, the safety and efficacy of CAR-T was seen as second-line agent. And it was seen that 78% of the patients achieved complete response, and the overall response rate was 89%. And this was a really good response rate. And there's one thing, if we are using CAR-T, if as soon as higher up in the list, if we are using CAR-T, the response rate would be better. If we use it at second line, third line or fourth line, the response rate is going to go really low. So coming to the case 2, this patient was he was a refractory, primary refractory DLBCL. He was counseled for CAR-T. He was given bridging therapy with acalabrutinib for 3 months. After that, he was given, we gave this patient CAR-T infusion in June. Prior to that, we had given lymphodepleting therapy with flu-cy-based regimen. This patient has been in follow-up since then, and at day 28, he has achieved partial response at least, and he is currently doing well. So suppose a patient has achieved partial response only after CAR-T, which was the second line agent, so what next? So CAR-Ts, they are supposed to be the living drug. They persist in the circulation really long. And patients who have achieved PR at day 28, they still can go into CR at 3 months or further up to 1 to 1.5 years. It has been seen they can achieve the complete response. Coming to case 3, 58 years old female with a cervical swelling, no other symptoms. There was a single lymph node which was 3 to 3.5 centimeters, biopsy confirmed follicular lymphoma grade 1 or 2, stage was 1. So she received ISRT 24 grays. She relapsed 10 years later with small cervical axillary lymph node with low tumor burden. As per the GLF criteria, she remained asymptomatic. There was another case, 45-year-old man with follicular lymphoma grade 2 and Arbor stage 3, high tumor burden. This man was treated with R-CHOP followed by 2 years of Rituximab maintenance. He presented with a disseminated disease 16 months later. Repeat biopsy confirmed follicular lymphoma, same stage. And patient 3 was again follicular lymphoma grade 1 and Arbor stage 4, treated with 6 cycles of Benda-Ritux. 5 years later relapsed, same stage and same follicular lymphoma was the diagnosis. So how to plan treatment in follicular lymphomas? So things that we have to consider is whether it is a strictly localized disease or it's a disseminated disease but low tumor burden, or it's a disseminated disease with high tumor burden. So how do we decide the tumor burden? So there is a GLF criteria for that. So any lymphoma or any lymph node, single lymph node, if it is more than or equal to 7 centimeter in size, or 3 or more lymph nodes of size more than 3 centimeter in diameter, with presence of systemic symptoms, symptomatic splenomegaly, ascites, pleural effusion, cytopenias, or circulating lymphoma cells. So these are the criteria for the tumor burden. If any of it is present, then it's a high tumor burden. So a patient who has not received any chemotherapy, if the tumor burden is low or it's a frail patient, there we can go for a wait and watch policy or give rituximab single agent or radiation if it is localized. If there is a high tumor burden, early progression or a fit patient, there we can go for a immunochemotherapy. It can be a Benda-Ritux based regimen or R-CHOP based regimen. If a person has already received Benda-Rituximab, so we cannot give R-CHOP after that. There hasn't been seen any significant survival or PFS benefit with that. So we can go ahead with Len-Rituximab based regimen. If a person has received R-CHOP, there if we need the second line regimen, we can go ahead with Benda-Rituximab. And if there is a low tumor burden and late relapse, frail patient, there we can also go ahead with the wait and watch policy. So I'll just skip with the CAR-T in relapsed refractory setting, and basically CAR-T was also studied in relapsed refractory follicular lymphoma, and it was seen that the overall response rate was really good in follicular lymphoma. The CR rate was 75%. And I'm talking about this because generally low-grade lymphomas are considered to be incurable lymphomas. They persist for a really long time, or they come back again and again, and they are really problematic. In such cases, CAR-T is a solution which is available in the market. Next is case 3. Again, coming back to the cases. Patient 1 who relapsed after 10 years, low tumor burden, single lymph node. We could have given rituximab 4 weekly cycles followed by 4 more doses 2 weeks apart, or we could have done the wait and watch policy. Patient 2 who relapsed, who got R-CHOP, relapsed after 16 months, and again it was follicular lymphoma. There the options are R-Benda or autologous SCT. And patient 3, 67 years old, follicular lymphoma grade 1, stage 4, 6 cycles Benda-Rituximab were given, relapsed after 5 years. Here the option is either Len-Rituximab or the newer agents. Coming to case 4, this case is really good. This is a case of T-cell lymphoma. I'll tell you right from the beginning only. He was a young man. He presented to us with back pain, shoulder pain, and he had eosinophilia. And MRI showed epidural lesions with impending spinal cord compression. Workup for when we saw eosinophilia, it was in the range of 60%, 70%. Total count was like 50,000, 60,000, something like that. We were thinking on the lines of it was clonal eosinophilia. We did MPL panel, fish eosinophilic leukemia panel. We did everything. We did a bone marrow. Bone marrow showed eosinophilic precursors, but all these panels which were done to establish the clonal nature of eosinophils all came out to be negative. So, and we did a CLPD panel also. No monoclonal B or T cell population was seen in the flow cytometry done from the bone marrow aspirate. PET CT showed jejunal loop thickening, prevertebral nodular lesions, and multiple bony lesions. So we did the jejunal biopsy, and this jejunal biopsy showed atypical large cells in the intestinal epithelium, and they were positive for CD3, CD7, CD30, granzyme B. So this was a case of high-grade T-cell lymphoma, and it was enteropathy-associated T-cell lymphoma because associated crypt distortion and whatever features were needed for enteropathy-associated T-cell lymphoma were present in this case. We were not able to establish the association between the gluten enteropathy, sensitive enteropathy, and T-cell lymphoma in this case. So we had sent a HLA-DQ2 typing for this patient, and that came out to be positive. In case of peripheral T-cell lymphomas, enteropathy-associated T-cell lymphoma is a type of PTCL, and there are different types of T-cell lymphomas, but if you can see, this is the NCCN guideline. This is not very clear here. Anaplastic large cell lymphoma it's a good kind of lymphoma, even if it's bad. But the first line regimen is brentuximab vedotin plus CHP. Basically, all the ALCLs, if they are CD30 positive, will use something which will target CD30. So brentuximab vedotin is the drug. So BV-CHP is the treatment of choice. And for other T-cell lymphomas also, brentuximab BV-CHP based regimens, that is the treatment of choice. So whenever you get a report of T-cell lymphoma, what you should check for is whether it is CD30 positive or not. If it is positive, it's a good news. If not, in that case, we can give plain CHOP or CHOP with etoposide. But one more thing, in cases of T-cell lymphoma, except for ALCL, all other T-cell lymphomas should be given first-line consolidation with autologous stem cell transplant. So there was a study, EATL-001 trial, and this we had communicated with the author of the trial, and we wanted to know how to proceed with our case. In our case, we gave 4 cycles of BV-CHP. The patient had achieved the complete metabolic response. And after that, we wanted to know how to go ahead. So as per this trial, they had given 2 cycles of high-dose methotrexate and etoposide to the patient, 2 weeks apart. And after that, they had taken the patient for transplant. So we have done the same. We gave 4 cycles of BVCHP followed by 2 cycles of high-dose methotrexate and etoposide, gave beam conditioning to the patient and proceeded with ASCT 6 weeks later. At present, this patient has reached day plus 75, doing well. Last case, case 5, 21 years old female. She presented with abdominal pain in surgery OPD. She had a history of TB in 2021, was treated for that, multiple surgeries, dermoid cyst, excision 2021, and she had multiple GV calculi with complex left ovarian cyst. So when she was being treated for the same, multiple lymph nodes were seen in the abdominal region. 1 lymph node was sent for excisional biopsy and PET CT was done. So PET CT picture was not very much suggestive of a lymphoma. There were multiple lymph nodes above and below the diaphragm, and on the lymph node excisional biopsy, it established the diagnosis as classical Hodgkin lymphoma. So we were thinking on lines of TB. We thought it had TB had recurred, but this was a case of Hodgkin lymphoma. And now, in case of Hodgkin lymphoma, do we still go ahead with ABVD in every patient, or is there something else that we need to do? So there are so many studies which have come for Hodgkin lymphoma for limited stage and advanced stage disease. In limited stage disease, again, nivolumab, you must have heard, it's a immunotherapy, anti-PD-1 antibody. So nivolumab, AVD, 4 cycles followed by 30 gray ISRT versus sequential nivo AVD, 4 cycles plus 30 gray ISRT. This study was done and showed 3-year PFS rate of 100% as compared to 9. More or less, it was the similar response. Then there was the breach study which was done, and this was BV-AVD, brentuximab vedotin, which is anti-CD30, and in Hodgkin lymphoma, we know that Hodgkin lymphomas can be CD30 positive. So that also showed very promising results. In advanced stage also, multiple studies had been done, and it was seen that BV-AVD, nivo-AVD were good. And there is a new regimen which has again come, that's called BRICAD, which incorporates brentuximab vedotin with other drugs. Previously, we used to know that either we have to give ABVD to the patient or escalated BFOP to the patient as per the ESMO guidelines, but the current guidelines have changed a little bit. In case of early stage favorable HL, we can give 2 to 4 cycles of combination chemotherapy followed by IFRT to a dose of 20 to 35 gray. But if it is early stage unfavorable HL, in that case, we have to give 4 cycles of chemo with IFRT, generally ABVD with 30 gray IFRT, and we can also use BV-AVD or nivo-AVD. As per the current guidelines for advanced stage HL, they have mentioned that you either start with escalated BFOP or after 2 cycles of ABVD, if your response is not very good, if the DS score is not less than 3, there you have to switch over to escalated BFOP from ABVD. But the current regimens or the current guidelines tell something else. The newer regimens have come in advanced Hodgkin lymphoma, and the regimens which are being preferred now are the nivo-AVD, BV-nivo, BRICAD and BV-AVD. So suppose there is a patient who is young.
Dr. Karuna, just 1 minute is left for you to...
Yeah. So basically, there were 2 studies which were done in case of Hodgkin lymphoma, and it was seen that BRICAD was as good as escalated BFOP in advanced stage Hodgkin lymphoma. And second was whether to give nivo-AVD or brentuximab based regimen in Hodgkin lymphoma. So contrary to the belief that if Hodgkin lymphoma is CD30 positive, we should go ahead with BV based regimen, it's not so. Brentuximab vedotin has done better in T-cell lymphomas, and in case of Hodgkin lymphomas, it's the nivo based regimen which is being preferred nowadays. Again, these are the NCCN guidelines. I'll skip. Finally, this patient was stage 3 advanced disease. She received 6 cycles of nivo-AVD, currently in remission 6 months post-therapy. So the take-home message is curability in DLBCL is heavily influenced by age, IPI, scoring, cell of origin, whether it is GCB type or the ABC type, presence or absence of certain chromosomal rearrangements such as MYC, BCL2 and BCL6. Treatment regimens depend mainly on prior treatment history, duration of response after previous treatment, patient age and frailty. Novel treatment options have changed the treatment paradigms in lymphomas. Since the advent of CAR-T, antibody drug conjugates, small molecules such as PI3K inhibitors and bispecific antibodies, and CAR-T as a second-line treatment has brought a really good paradigm shift in the management of large B-cell lymphomas. For peripheral T-cell lymphomas, if it is CD30 positive disease, then go ahead with BVCHP, followed by consolidation with ASCT in first remission. And in case of Hodgkin lymphomas, early stage disease, shorter course of chemotherapy with radiation. For advanced disease, longer course of chemotherapy without radiotherapy, and newer agents such as BV and anti-PD-1 antibodies are incorporated into the frontline regimens with really good response rates. Thank you.
Thank you, Dr. Karuna, for a nice presentation. Since there is a lack of time, so those who are interested in asking any question, they can ask when
during the lunch time. Yeah. Thank you very much.
Thank
We could
you very
have
much.
closing comments by Professor Mishra sir. So would you like to just pass home messages? All lymphomas are curable and we should get it that way. Thank you so much. So now I request all the chairpersons to please come forward. Would like to call upon the chairperson for an extension. Dr. Nirun
सर इस साइड है जी आप इस साइड है जी हाँ
Dr. Ramesh Vyas, Dr. Nirdesh Jain, Dr. Manoj Mishra, Dr. Ara
Yes, sir.
Saxena,
सामने
Dr.
देखिए।
Anurag Srivastava. Please come and take your
वेट
seat.
सर एक मिनट थैंक यू
So the next topic is value and impact. Saxena,
आइए सर
and I hand over
आप
the
भी मैम आ
mic to
जाइए
the
थोड़ा
chair.
बीच में आप आ जाइए सारे लोग आप ही आ जाइए यस यस थैंक यू सर